All right, we'll make a start. Thank you so much for coming to this impromptu breast educational meeting, and thank you so much, Timothy, for coming all the way from Geneva to Cambridge. Timothy is a medical oncologist at the hospital in Geneva, and essentially the reason he's come to talk to us about is because together with Shruti, he's published on the use of CDK4/6 inhibitors, and he has written a lot of thought-provoking papers, both in the space of breast cancer as well as in evidence-based medicine and clinical trials in general. So it's a great honor that you've made your way here to Cambridge to speak to us tonight.
Thank you, Dr. Heno. Thanks for the kind introduction. I will just put my setting here. Maybe very briefly, my clinical focus is sarcoma and head and neck, and I'm a clinical oncologist seeing patients, but of course I have also research interest in sarcoma, head and neck, but also for pragmatic trials and methodological aspects and evidence-based medicine, and this is the main focus. And the adjuvant setting is really, really interesting to me because, you know, it's really touching a lot of people, and we'll be speaking about that today. I didn't want to focus only on CDK4/6 inhibitors and to make a broader point, just maybe to, I know some of you, and but how many clinical oncologists are in the room? Okay, how many, we came to the definition, but how many are breast cancer oncologists? Okay, and how many medical students? Even if we are learning all our life, but okay. Okay, thank you very much. So it's my great honor, it's my great pleasure, and again, thank you for the invitation. So this is the plan today. We'll be talking about Kaplan-Meier, we'll be talking about informative censoring. So Kaplan-Meier is really an introduction for informative censoring. CDK4/6 inhibitors, combining novel adjuvant drugs. This is maybe the topic that will be more heated today. We will see. I don't know. Post-recurrence therapy, why it matters, and what about quality of life, including financial toxicity with novel adjuvant treatments. Of course, we'll have time for questions. This is a 45-minute talks. We have a lot to cover, but first, let me introduce what you can hear, what I call talking points, because I think these are talking points, but this is the kind of sentences I have been heard or told. I know an expert who told me he has very good results with adjuvant CDK4/6 inhibitors. Let's just think about it. Does it make sense to say this? And we'll have some answers during the talk. Another thing, you know, because my talk is about statistics and decision making, you know, somebody tell me, you know, doctor, you like statistics, but you know, for the patient, it's about having the recurrence or not. It's 0% or 100%. And it reminds me when I was a child, you know, I wanted to play the lottery. And I say, okay, the lottery, either you win or you lose. So it's a 50-50% chance. And with time, you know, I realized it was not so easy. So back to the talk, the Kaplan-Meier method. So I think what is very important, this is a seminal paper from Kaplan and Meier, 1958, and the title, non-parametric estimation from incomplete observation. I think this is really the key, and you will see why. So these two highly regarded researchers that are really making it a strong method that we are using daily. So this is patient trajectories in clinical trial. As you can see, patients do not enroll the first day. You know, you don't have all your patients enrolling the first day. Patients will enroll progressively from the starting of accrual. I have a laser point here. You can see it. You can see it here, not here. So you have the start of accrual and you have the data cutoff. For instance, the first patient here, he starts to enroll in the first day, and very soon he presents an event, which is death. This one has been censored, lost to follow-up. This one has another event, and we will come to that. Is it the same event? Here, another event. And this one is censored not because loss of follow-up or other reason, but just because it's data cutoff date. So it's date of analysis, and the patient is being censored. So as you see, there's a lot of incomplete observation. What happened here, what happened here. And this is really the key, the core of the method of Kaplan-Meier to take into account these incomplete observation. So this is how you will get your Kaplan-Meier curves. In a clinical trial, each patient either have an event or are censored. There is no other way. There is not a third condition. Every patient is an event or censored. This is basically a Kaplan-Meier curve is like that. This is really basics, but sometimes it's good to remind some basics. The steps are the events. Sometimes you have a big steps. It can be either because you have a lot of patients censored. I will come to that later. Sometimes it's just because you had many patients, more than one patient having the event at the same time. And censoring, this is those tick marks, often tick marks, sometimes circles, sometimes cross, a lot of ingenuity in how to present this censored patient. But basically, the definition of censoring is the point in time after which you can no longer capture the event, for whatever the reason, and this is very often indicated by these tick marks or circles. And here, I really want to introduce you to the importance of these censoring events and why it can be really important in how you interpret the data. A core assumption in Kaplan-Meier is the conditional probability, is that you have to be at risk at some point of time to present the event or not. And this is really the core point of the number at risk. And to be at risk, you have not to have presented the event, nor been censored. You have software that are doing that for you, and this is an example, recent example in small cell lung cancer. Durvalumab against placebo. This was a New England Journal paper, but basically my point here is really a normal curve. You have a lot of censoring after 30 months, and this is because of data cutoff. Those patients are still on the trial. They did not present the event, but you can really see what is expected, mostly late censoring. Is it clear for everybody? These are basics, but sometimes basics are really helpful. Now, let's come to even more basic things. How to generate a Kaplan-Meier curve? You take a spreadsheet, and this is a real spreadsheet. This is not a trick. This is a spreadsheet I used to generate this curve. So your patient, after 2 months, will have an event status. 1 is an event. The other patient at 3 months is censored. Another at 4 months, again, have an event. 5th month, an event, and 7 months censored. You run your analysis, and this is your Kaplan-Meier curve. The main point I want to highlight here is that the censored patients are no longer at risk, and this has an impact on the curve. Fewer patients, larger steps. The steps of the event is larger. As you can see here, you have a step, then you have a censored patient. Yeah, next step is even larger. And let's go even beyond that. Look, the patient at time 7 is censored. Imagine he is now early censored. Okay, censoring happens after 3.5 months. There is no events between them, so it will go here. And look at the curve. The step is even larger. This is really a basics. This is really how it works. But you will understand why it's so important, why early censoring particularly is very, very important. Now, what is informative censoring? And this is a core assumption, is that at any time, patients who are censored have the same survival prospect as those who continue to be followed. Mainly, censoring should be non-informative, should occur completely at random. For instance, patient moving abroad. This should not be related to the group allocation. It should be totally at random, like in this image, George Delatour, the dice players. But the question is loaded dice, and this is where informative censoring can happen. If there is a link between the probability of being censored and the probability of experiencing the event, then censoring become informative. Provides information about the risk, of experiencing the event. All this is a bit, technical. We'll come to concrete example very soon. So what do you have to look at when you are considering informative censoring? You have to look at two things: the number of censored patients. So the number of censored patients, in many publications, like in this publication from the Lancet group is really making this effort of reporting all the censored number of patients. You can see in brackets at each time interval, they are reporting the number of censored patients. Here, there are very few censoring events early, and then there are others. It's just an example of a Lancet publication. This really allows you to have a quick and easy assessment of potential imbalance between arms, and it's very helpful when you have this published in a publication. Here, another example, Nivo-EP in MSI high metastatic colorectal cancer. This is also a recent New England publication. And here you don't have the brackets. So in New England, it's not always reported. And you know how you can appraise the potential for informative censoring when you don't have those data. Is somebody here know how you would do? There's some clue usually. The clue is in this kind of figure that you often have in the paper that really tells you, how many patients did not receive the treatment at all. It's really very, very early censoring in a sense. But it's not enough, this kind of data is not enough. Another way to do, the ideal way would be data sharing. I come to that later, but another way to do is digitize the curve. So I will come to that. Digitize the curve is really using software to abstract X and Y coordinates, and you run a code, and then you have synthetic individual patient data that will allow you to do curves that are very close to the digitized curve. So how you do that, and it's not so difficult to do, but you have to learn it and to do it a couple of times to be, that it becomes easy. But you can see here the green is really the way with your software you can digitalize and have a lot of X, Y coordinates. And you do it for one arm, you do it for the other arm, then you run some code, and then you have your synthetic individual patient data, and you run again a Kaplan-Meier analysis, and you have these curves that are very, very close to the other curves. And what is really great with that, you can have estimates of the censored patients. So for instance, here, we have 23% of censored patients after the first time interval as compared to 2% in the other arm. So it's more powerful. And you will see after that we can even do even more powerful analysis with that. The second thing, so we have seen the number of patients censored. Now the reasons for censoring. Now I will be talking about two things. First, it's toxicity-driven censoring. This image is really, trying to illustrate a frail patient. A frail patient, you can expect a frail patient to be at higher risk of suffering from toxicity and at the same time to be at higher risk of presenting the event. And this is the core concept of toxicity-driven censoring. It's a bit in a race. If you just account for people going to the finish line, if somebody is suffering too much and just quit, and if you don't count this person in your total count, this will skew your overall results. And this is the same with toxicity-driven censoring. For instance, somebody is really at high risk of presenting the event maybe in 2 or 3 weeks, but will suffer from toxicity, will quit the trial, and if the person quit the trial after 3 or 4 or 6 weeks, even if there is a progression, then it's censored because for many surrogate endpoints, it cannot be considered as an event. So this will retain individuals with a lower risk of the event, and it's typically favor the experimental arm, which is more toxic, often. Any question about that?
Actually, could I ask a question? Why do you think the New England Journal doesn't insist on having that? Because that's so helpful when we're trying to work out.
Sorry.
Why does the New England Journal not
Yeah, yeah. Good question. I cannot tell too much about that because we are an ongoing project on this. But I think, yeah, I think the decision of the Lancet group was really helpful in many ways. It's almost always reported, and the New England is not doing that. The answer, I mean, I don't know, but I agree with you. These data are so helpful. There may be a way, we are working on that, but I can't tell too much at this time. So now disappointment-driven censoring, maybe just a pause with these AI images that are very helpful. I just want to say that I didn't, prompt the color of the slippers, but they are very nice, but it's not my prompt. It's just like that, Okay, I just drink a bit. So this disappointment-driven censoring is less known. It's very interesting. Here again, the analogy of a race, and many of these analogies are inspired or made by Vinay. So I just want to acknowledge this. And I think this is really helpful. And I want to make also a point because people can say, okay, you are making fun or making funny and cancer is serious. It's not, I'm not denying it's very serious, but those analogies, those images, I think sometimes are very helpful to understand some concepts. So this is just a parenthesis I wanted to make. So here, the example, I think you are bringing some people, to make a race, and they are all arriving, and they are saying that they will run with slippers. Of course, there are already disadvantages because they will run with slippers. So their overall time is not good as compared to another group with proper shoes. But some people will quit, will say, okay, no, I don't want these slippers. I mean, I will take another race. I will go in another place. And the idea about disappointment-driven censoring is that those people quitting, going outside, are healthier, stronger, more connected. And the example in a trial is when you have a disappointing control arm, if you have less option, if you are frailer, if you are less connected, you will stay in the trial, even if the control arm is bad, is suboptimal, and we have examples of that. And if you are very well connected, or if you have many options, then you will say, okay, stop this, I go. So this, again, will retain individuals with higher risk of the event, because the frailer patient will stay in the control arm. So if you take those two and you mix it, it can bias a positive result. Okay, now let's take an example. I know some people here are taking care of patients with cancer, prostate cancer. So this was a CONTACT-2 study. Any of you familiar with this study? Okay. Maybe you participated in enrolling patient? Okay. So it was patient with progressive metastatic castrate-resistant prostate cancer that already have received, as you can see here, prior NHT, so it's novel hormone therapy, which is also called RP. They were randomized into cabo-atezo, cabozantinib atezolizumab, which is known to be toxic, or the control arm is a second RP, and this is called RP switch, and this has been repeatedly described as a suboptimal control arm because we know that the activity is mostly, I mean, you can argue with one way or the other way, but basically it's a suboptimal control arm. So more toxic experimental group and suboptimal disappointing control group. So the result in CONTACT-2 was the benefit in PFS, and we will see this is a very good example of both kind of censoring, because it is possible that in the experimental arm you have toxicity-driven censoring, and in the control arm you had disappointment-driven censoring. How you can explore that, and now I will introduce to this application, the Breaking ICE application. ICE stands for Informative Censoring Exploration. So this is a shiny application I have developed, and it can estimate both numbers of censored patients, and you can visualize the impact of potential reasons for informative censoring. Let's take the contact 2 example. This is a short video, so I will try to explain in the same time. So you can select trial. So this is, maybe I will just pause. One advantage of the application, you don't have to digitize yourself the trial. Somebody, usually me, is doing it for you. So I think that's helpful, and if you write me something, I can, an email, and if I find some time, but usually I can do it. I can also, digitize the curve. So I think this is a really good strength of the app. There's already loaded trials. So you can select a trial. Here we are talking about contact 2 trial. We will reset the parameters to 0. So this is the curves without any assumption. And you can select a time frame of the number of censored patients. It's not the total number of patients, it's only the censored patient. And you can select a percentage of them and select a type of modeling informative censoring. You can select toxicity for the experimental arm. You do the same, 6 months, 50% of them, disappointment. And then you see the result on the curves. Curves are changing. And you see the result on the statistical output. And here it's no longer significant. So with very conservative assumption, you change a small percentage of censored patients. I really insist, because sometimes people say, okay, you modified the event of patients that are not censored. It's only on censored patients. And you can really change your outcome and visualize it. So again, it's estimation. It's based on digitized curve, but I think it's very helpful. So this led to this publication with Vinay Prasad, equal censoring, because there is equal rates of censoring, but the reasons could differ, and there is really a rationale to think it happened. And this was this publication. This application will be published in a very well-known journal that you can see here. I don't tell it out loud, but this should be soon. So to summarize my key points about Kaplan-Meier, I think it really helps the interpretation to know the principle of how it's generated. It really helps also to, this was the whole goal of the application, is really to make informative censoring more approachable, more palpable, more direct. So it's not a dry concept, a statistical concept disconnected from clinical practice. You can bias results and make them unreliable. You should examine the numbers, percentage, but also the reasons, potential reason for censoring, and explore those with the app is a personal advice. Any question about that? I just checked the time, it's okay. Now we'll come into the core of the talk, and this is a paper led by Alison Aslam, Shruti Ranganatham, which is here, which is a great researcher in our team, also participated. She's in the 5th medical year, and I think all is in the title, uncertain benefits, guaranteed harms. I will go into the data and try to explain why I think there's a lot of uncertainty about many things. It's really, critical appraisal of data. It's not medical advice, and we will be talking about that, I think, in questions. Is it a hot topic? I think that's the first thing to ask, and that's a reason I was so interested in this topic. Breast cancer is the most frequently diagnosed cancer worldwide. 75% of cases are hormone positive, HER2 negative. And here are, this is data, recent data, trying to figure out how many proportion of patients are stage 1, 2, 3, 4, and basically 2 plus 3. Switzerland and the UK are basically the same. It's 45% of cases. So the Natalie trial, which is ribociclib for 3 years, could affect up to a third of newly diagnosed breast cancer, which is, again, the most frequently diagnosed cancer worldwide. So I think that's really why this topic is so interesting, fascinating, and potentially impacting many patients. Hot topic, yes. Trial designs. Basically, I think the most important thing here, we have 2 trials. Monarchy, and Monarchy excluded N0 patient. In Natalie, as you can see, T4N0 are included, T3N0 are included, T2N0 according to genomic risk, but basically it's broader. It's really broader than Monarchy. If we go into more details, the Monarchy trial, as you can see here, you should have positive lymph node and some characteristic of aggressivity, and you were randomized between abemaciclib for 2 years with standard of care endocrine therapy, no restriction here. It's important. It's a very important difference with a Natalie trial, and so the primary objective was invasive disease-free survival according to the STEEP criteria. In Natalie, it was ribociclib, 3 weeks on, 1 week off, primary endpoint EDFS, but the control arm was only letrozole or anastrozole, and in men or premenopausal women, they had to receive goserelin. This is, I think, a very important point. Why is it so? It's because of issue with QT prolongation in association with tamoxifen. So that's why this trial was designed like that. And now 3 years of treatment. Another difference is the dose. The dose here is different from the dose given in the metastatic setting, which is 600 milligrams. Primary endpoint is the same, invasive disease-free survival. We'll come to that. Any question about that? I'm sure you are very familiar with the design. Efficacy data, this is significant. I will come back to the delta because it's updated very often, I would say. The Natalie trial, and this is a bit to have some relax with a Vinay point. If you can fit a laser pointer between the curves, you can give the plenary session. And here, to be honest, I put the laser point, but was not so easy. But I don't want to argue. I mean, hazard ratio 0.75, and it's really significant. There is no argumentation about that. So here, it's key data from both trials summarized, and I think here it's important the absolute gain. So that's why I said it's changing, because you have all these conferences. For instance, I will just exemplify that. So this is the data from the New England paper. So Monarchy, it's 7.6% difference at 5 years. In Natalie, it was 3.3% at 3 years in the New England Journal paper. Then you have ESMO. Oh no, sorry. This is this is the last publication from February. So the 3 year. So it's a final analysis of EDFS. Now it's less, than 3.3. So the number need to treat is increased. But we have in ESMO 2024, so 3 months before, we have the 4-year results, and now it's more, it's 4.9, so the number need to treat is 20. To be honest, it's difficult to follow all this data. I don't know how you do in breast oncology. You are going to ESMO, San Antonio, and all that. Sometimes I feel it's a bit too much. Okay, back to this.
Context for the non-breast cancer.
Sorry?
Just for context for the non. So presumably, still no overall survival difference.
Oh yeah. Sorry. Yeah, sorry. I had to say it. So yeah, it's obvious, but yeah. No overall survival. So it's not yet mature, but no overall survival benefit.
At those stages.
Yeah. So that's why the efficacy data is mainly that. So back to this sentence. I know an expert, a key opinion leader, and he told me he has very good results with adjuvant CDK4/6 inhibitors. Somebody want to comment? Do you think you can say that in the adjuvant setting in general? Okay. I don't want to put you on the spot.
I don't think it is particularly, and I don't think that we quantify toxicity, actual toxicity, well enough from looking at outcome. Because I think we look at outcome as survival, but actually, particularly in early breast cancer, people don't just want to be alive, they want to be well and alive.
Yeah. So I get your point. Your point is about the clinical relevance of the EDFS event. But this sentence is to me a bit surprising. It's not about the trial. It's about, in my practice, I have good results. And this, I find it a bit, that's why I say it's a talking point. Because
the question I would ask is, does that expert have a practice for 1,000 patients?
yeah. I
Because
mean,
if they don't, then they can't
it's
take
impossible
that
to know
evidence.
if your patient, even if they recur or not, if they benefited. It's impossible to know. And that's the point I really want to make here, because basically this is really the last update, the 3-year update of Natalie trial. So it was just published in February. Again, they have published the final analysis of the 3-year EDFS event. But you know that 87.6% of patients had no events regardless of therapy. 9.3% had the event regardless of therapy. And 3.1% avoided an EDFS event with the therapy. So how can you know if your patient benefited or no, even if there is an event? If there is no event, you cannot say it's thanks to the treatment. You cannot say it. That's why I find this sentence a bit strange. So back to your point, the relevance of the endpoint, EDFS. I think a very important point to make, it's a composite endpoint. So as you can see, the event can be death, can be local regional invasive recurrence, can be distant recurrence, can be many things. And on the curve, there is no distinction. You don't have steps that are wider if you have a death. I mean, all is the same. All is counting as events. And this is very well reported. EDFS definition is all these events can count as an event. And this is very well reported in both trials. This is just an example in the PFS endpoint. PFS is the equivalent of DFS in the advanced or metastatic setting, and is a very nice work from Anushka Valia and also with Vinay Prasad. And they showed that in many trials, the breakdown of the results is not available. You don't know which part of survival and which part of progression is in the trial. Here we have the breakdown, and what I found very interesting is that the survival part is not so huge. It all depends on your interpretation, but it's less than 10%. It's 9% in Monarchy, 7% in Natalie. So this means that the proportion of deaths among these events are 9 and 7%. And I think it's really important to understand that and to explain that to the patient, because when you say disease-free survival, there is a word survival. And I think this word really matters for patients. I think we should be clear in the way we explain the endpoints. I know it's not possible with all patients, but I think it's really important to avoid this term to be misinterpreted. Toxicity, here, those familiar with the medicine, diarrhea is often a concern. I won't go into all the toxicity, but you have a toxicity with these agents. To me, what is more concerning is the death. So again, it's treatment emergent adverse events. It's not treatment related, but most regulatory agencies are looking at treatment emergent adverse event, because we know that to put the relation between the treatment and the adverse event is not always reliable. And here, 2 of the 15 deaths were assessed by the investigators as possibly related to the study treatment. In the control arm, no deaths were considered related. So we have 2 potential toxic deaths, which is to me concerning in the adjuvant setting with no overall survival benefit yet. For Natalie, we have other type of toxicity. You have less issue with diarrhea. You have some issues with liver enzymes and other neutropenia and other side effects. I will also go to this point, the point of on-treatment death. And this also was a worry, and this is from the last update. But you have 20 patients that had on-treatment deaths against 9 in the hormonotherapy alone group. and a lot of COVID-19 related deaths, 6 versus 1. And this is unexplained. In the paper, they say there were no myelosuppression, or I think it was worded like that. And to me, it's also, you know, a red flag. Why you have this imbalance in on-treatment deaths? Definition of on-treatment deaths is up to 30 days after it's on treatment, or up to 30 days after the discontinuation of the treatment. Now, informative censoring. That was the first part was aimed for. This is the analysis done by Tom Meyerson and colleagues with Jan Tannock as the last author. They used other methods than I have been using for the NATALEE trial, but basically they took all the excess censored patient in the abemaciclib group and turned their censoring status into events using some methods. They made a paper, very famous paper, Lancet Oncology, and their statement was pretty strong. Adjuvant abemaciclib should not be prescribed to women with high-risk estrogen receptor-positive breast cancer. I know this paper was highly commented. What we did is, in the NATALEE trial, we again used digitized curves, and this allowed to do this analysis. So it's very conservative. In the experimental arm, in the first 6 months, we took 10% of patients, assuming there could be some toxicity-driven censoring. Those patients are taking a pill. In the other arm, they are not taking a pill. And again, maybe I should have told, but both trials are open label. Both are open label. In the other arm, you may have some patients being disappointing to be here. Maybe they want to seek for abemaciclib because NATALEE was after monarchy. And maybe I think one potential concern was patient being on tamoxifen and then enrolling in the treatment, being assigned in the control arm. So they have to take now anastrozole or letrozole plus goserelin, but they were before on tamoxifen. So maybe this was some disappointment censoring. So it's very conservative. You take only 10% of the censored patient over the first 6 months. You modify their events of censoring with toxicity into an event, and the disappointment type of when you check disappointment, you modify the time of censoring. Instead of being early, it will be late censoring. And without, you get, again, the benefit is no longer significant. So this is really about the fragility, you know, the reliability of the gain reported. When you have this number of censored patients and you make small assumption and it's an open label trial, this is really about the reliability. Yeah, please.
How do you know that those, what you say, conservative estimates of the 10 and the 10 are...
How I...
The company have that data.
So how I choose 10, for instance? Yeah. So what I try to do is to do the most conservative assumption to try to see if this modifies the results. When I choose 10, or if I, with 5, it's not modifying this, you know. I really try to see if I have to modify, you know, all the censoring data of my patient, I think it's implausible. But if I do very small assumptions and it's modifying the statistical output, then I really start to be worried. This is about the reliability and the fragility in the sense of the data.
But then how do you know, can you then confirm that hypothesis by knowing?
So ideally, data sharing would be ideal with the reasons, also the reasons for censoring. It's very rarely reported. You can ask for them, writing a New England Journal letter, but I don't know if you tried to write New England Journal letter. My record is not so good. So they say they have no space, but it's online, you know, but okay. So yeah, no, the reason for censoring, but I'll come back to data sharing later. To straighten the point of informative censoring in those two trials, I think we have also, you know, the Penelope trial, which was a placebo-controlled trial, and had no imbalance in early dropout. We have another trial, the PALACE trial, with less imbalance, and both were negative. So some say, okay, it was not as long. Some say, they are not as well. These are not the same drugs. So there's a lot of debate. But I think it's reinforcing this. And overall, this is from our paper, we maintain that the gain reported in both rounds are potentially compromised by informative censoring. Again, it's an hypothesis. We don't know. But this, to me, it really flags the fragility of the results. To finish about CDK4/6 inhibitors, I think there is this point to make about sample size inflation. You have a lot of patients, and this was a work by Kay and colleagues that show, the sample size is really growing over time in oncology trials, and sometimes you have this statistical significance which is not clinically relevant. The classical example was erlotinib bevacizumab in pancreatic cancer. It was a couple of days difference, but it was statistically significant, and it was highly criticized for that. And the open label design, this is really surprising. We had a lot of products tested in the adjuvant setting, and most, we'll come back to that also, but most are not tested against, are really tested against a placebo. And I don't understand what is the justification. I think both companies would have the money to afford a placebo and to make this trial, and I think it's really introducing this potential for informative censoring and also a risk of bias in quality of life assessment. Just a last point about Nathalie. I think Nathalie, the fact that there were no concurrent tamoxifen use, I think there were a risk of overtreatment of some patients because they were, and we know that 30% of them were on anti-estrogen. I would assume it was tamoxifen mostly. And then they were randomized, and if they were in the control arm, they had this anastrozole or letrozole plus goserelin. And I think there were a risk of treatment, and maybe some of them quit the trial. This was maybe part of the disappointment censoring, if some disappointment censoring happened. So my point about adjuvant CDK4/6 inhibitors in breast cancer, informative censoring, I think it's likely, because all the reasons I explained. Even assuming those estimates are reliable, I think we have to remember these are composite endpoints and to bear in mind the number need to treat, and I think it's really shared decision-making, informed decision, as you said, Dr. Abraham. Huge sample size, clinical significance, toxicity pattern. To me, the on-treatment death is a pretty concerning fact. I cannot really explain. I don't want to be, we don't have statistical difference in overall survival, but these deaths are a bit concerning to me. 2 or 3 years of treatment and financial toxicity, we'll talk about that a bit later. Waiting for OS, to be honest, I would be waiting for data sharing and real sensitivity analysis to really know if those results are really tangible. Data sharing. So I asked the Nathalie trialist, I asked the company if they could share the data. This is an ongoing process, let's see, but I want to share with you this data sharing statement that appeared in the New England, which is pretty damning because, as you see, yes, they will share the data, but you don't have nothing else in this report. I don't understand why the New England accepted that, but this is really, to me, deceiving, This is not data sharing. So on that positive note, as Vinay often said, we will go to another topic. Any question about CDK4/6 inhibitors? We'll have time for questions after. I'm a bit late, but we have some questions, so do you allow me some time more? Okay. Combining adjuvant drugs, the need for phase 3 trials. This is, I think, a very interesting topic, and it was a bit heated when we made some comments on social media. So, Sengalen, the very well-known, all experts, many experts in breast cancer are joining, and this was the question. A 43-year-old patient with stage 2 node-positive triple-negative breast cancer I'm sure some of you here remember the question. She's also found to have a BRCA1 mutation. She received keynote 522, so Pembro, perioperative Pembro. And at surgery, she has residual disease in the adjuvant setting. So for the non-breast oncologist, now I have to adapt myself, keynote 522 is Pembro before and after. So in the adjuvant setting, in addition to Pembro, she should receive, and why there is this question is because in patients with BRCA mutation and residual disease, there is a trial supporting the use of olaparib. Of course, this was not tested with pembrolizumab. So what is maybe not your answer, what do you think they answered? Or maybe your answer personally. What would you do in your clinic today?
Were the people answering American or European?
Very good question. Obviously there is a lot of American breast oncologists in this meeting, but I don't think the votation are separated into American and European. I don't think, no.
I think the Americans would get that, is it?
Yeah, I think you're right. I would be interested in what you are doing in your clinic, but they voted in a majority for giving olaparib in addition. And here again, an analogy. And this is an analogy. I was, talking with Vinay Prasad during a lab meeting about that. And at some point, I saw he was, thinking about something. And after a few seconds, he said, okay, let's see. And he really came out with this analogy. So let's say we have an energy drink, energy gel, and energy bar. And taken separately, each of them, if you give them to somebody, they will increase their performance and they will win the race. Some people will benefit, but not all, but they really will win the race. But taken all together, you will have stomach pain and it's impossible to run. I think it's a very good analogy. That's really what we are doing when we are combining treatment that have not been tested in phase 3 trial in the adjuvant setting. So we made this figure and it was just accepted yesterday night, during the night. So I'm very happy that I can present it to you. So this is the figure we made. You have both trials. Now we have mature data. So we have overall survival benefit, 5 patients out of 10, 5-year benefit in the keynote 522 trial. In the Olympia trial, it's 3 patients out of 10 after 4 years. These are rounded numbers. And this is a scenario that people think is more likely, but we don't have a clue if it's real. It's possible that the same patient are actually benefiting from Pembro and olaparib. In this scenario, you have added efficacy, toxicity not offsetting benefits, and so you increase survival. That was really the argumentation of the votation in Sengalen. But there is another scenario where you have overlapping efficacy. The energy drink, the energy gel, the energy bar will benefit the same patient. So there is no need to give all together. But here, toxicity is neutral. But there is another scenario where the toxicity offsets the benefit. Because when you combine, you don't know. And in phase 3 trial, and in this paper, we have some revision. Of course, it was not accepted just like that. And I really dig, into the data of Pembro plus olaparib. We have some data, but we don't have phase 3 data in patients in the adjuvant setting. And I think this is an issue. Okay, any question about that? It was short. Yeah.
This is very close to my heart, so I have to say this. Keynote 522 have told us that there is 17% of their patients are BRCA positive. They've done an HRD analysis, but they haven't done the simple analysis of BRCA patients and whether they actually benefit with the addition of IO or what that percentage benefit is. Which the cynical person might suggest that that's because there isn't a benefit or that the toxicity is actually
interesting. Very interesting. So, yeah, again, your point, we would like to have more data sharing. I know in the keynote 522 trial, there's a lot of also question about what is really the benefit of adding Pembro in some specific subgroups. And sometimes they report some data, but you don't have all the data you would like to have, and that's a frustration we often encounter. But this is very interesting. I will question you after that to have more data. Okay, post-recurrence, we are almost done. I would say maybe 10 more minutes. Post-recurrence therapy, why it matters. So why it matters, again, 20 FDA approvals since 2018 in the adjuvant space. This is a paper when we really addressed the issue of post-recurrence therapy. As you can see, again, placebo, 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 placebo. So most of these trials are tested against placebo. So ribociclib and abemaciclib are really outliers. Why they used an open label design, it's really outliers. Let's take the ADORA trial. I won't get into all the details. These are lung cancer, EGFR mutated lung cancer, localized, and basically they were randomized between osimertinib for, I think, for 3 years. Is there any lung? Yeah, 3 years. Against placebo. Primary endpoint, DFS, and other endpoints. This is the DFS results, and there is no doubt about these results. They are very impressive. EGFR mutated lung cancer is the oncogene addicted cancer. So people with these DFS results, were really arguing, maybe, we are just delaying, but we can, if we give osimertinib of people when they recur, we can, in a sense, save them. I don't know the term, but save them by that. We have to wait for overall survival data. There were a lot of debate around that. Some people say no, DFS benefit is so strong. Some people say no. I think we should not decide. We should talk with the patient, and the patient should decide. But there were a lot of debate. So again, it's a composite endpoint, and here we have the breakdown. For instance, death is minimal, but I agree there may be other endpoints that are relevant for patients. So, okay, that's the first part of the story. But now you have the overall survival benefit. So, Dr. you won't argue with this overall survival benefit. You won't say nothing. 10% absolute benefit after 5 years. What I can say? I can say some things. So the issue here, and it's really, really concerning, 37% of patients in the placebo group did have a recurrence which was not death and never received osimertinib. So look the difference between this and the 10% absolute benefit. If those patients would have access to osimertinib, would this 10% absolute benefit be maintained? We don't know. Okay, then you can say, okay, but osimertinib, there are other TKI, other anti-EGFR TKI. Okay, even with other anti-TKI, you have 12.5% of patients that had a recurrence and did not receive any TKI. Again, maybe the benefit would have been maintained, but I have some doubts. It would have been lower, I assume, and I think this is really important. So you can also visualize that. I have other application on my website, so I made some publicity here. But it's really, to talk with patients. I think visualization is interesting. Here you have the absolute difference, 10%, and you have the number of patients with recurrence not receiving osimertinib, and you can choose osimertinib, but you can also choose any TKI. How is this possible? Do you have a clue? How is this possible? Because it's shocking, why this patient did not have access to osimertinib.
I guess it isn't the argument that they were too sick when they recurred.
Yeah. You think it's that?
I don't think, that seems a very big number to be all sick, but
yeah.
Proportion would, I guess that's always the concern, isn't it, in the adjuvant setting?
Yeah.
Is that you might be able to give a person therapy, but if you diagnose them too late, they'll never get it.
Yeah.
There's a financial element as well.
Sorry?
There's a financial element as well.
Yeah, I think the main reason, that could be part of the reason. There are some patients that are too sick to receive any treatment. What was interesting in the data I showed you, it was recurrence excluding death. So maybe they were very sick, but we know that even osimertinib, even a patient that is very sick, I don't know in the UK, but in Switzerland, even a very sick patient will give osimertinib if he were never exposed to osimertinib. I think the explanation is really sad. It's that those trials, many of those trials are run globally, including in trials with poor or very little access or no access to standard of care after the trial is ending. And so this is really driving this post-recurrence care access. And we have studied that comprehensively in this work. And basically here is the number of patients receiving systemic therapy. And among them, so again, this is eliminating the part of those patients you say that would not receive any treatment. These are those receiving systemic therapy and how much of them receive standard of care. And as you can see, a lot receive suboptimal care. And this is our main results. 43%, the data were not available at all. In most data that were accessible, it was suboptimal, and overall, it was in 14% of trials they were assessed as appropriate post-recurrence therapy. So, yeah. Again, you can see there is different application with different table where I try to really keep track of all these trials in the adjuvant or neoadjuvant setting. The last point, quality of life, including financial toxicity. Quality of life here, again, I think common sense is important. You are giving a pill with side effects to somebody for 2-3 years, or I don't know, any other adjuvant treatment, and you are saying you are not affecting quality of life. I think you should, pause, and is it really possible? So we conducted this work, and we basically look at quality of life data with a really strict methodology, assessing bias, and our overall conclusion is that 90% of them had a moderate to high risk of bias. In other words, those quality of life data are not really reliable. We did a meta-analysis of the results, and we can see it's overall detrimental. It's non-significant with the usual threshold, but here the question, those thresholds were developed in the metastatic setting. Is it the same in the adjuvant setting? In the metastatic setting, you have patients suffering from active cancer, and I think those thresholds are no longer relevant in the adjuvant setting. So this was our main point. Financial toxicity, this is how you can calculate the cost to avert one event. You take the number need to treat. Here I took the New England Journal number need to treat. You try to estimate the average estimated cost per patient. Then you multiply, and this is the result for NATALIE trial, $11 million to avoid one EDFS event. Of course, as I have shown before, the number need to treat is moving. So this was a commentary from Tolani and Natarajan, and they estimated at 8.8 million, so it was better than our estimation. It was later. I think the NNT was better. It was 20. But we have made the same analysis a few years before, and here there were no abemaciclib and no ribociclib. And the point I want to make, it was already concerning, but now Monarchy and NATALIE, where it is here, but they are really outliers. They are really outliers. The prices were already, huge price. The median was between $1 and $2 million, but now we are, the costs are really impressive. Last is financial toxicity captured in quality of life assessment in oncology randomized clinical trial. Many times you have this quality of life data coming from trials. And I think one point is important is that many questioners are not assessing financial difficulties. 46% of them. We did this comprehensive study. The second thing is the study drug is mostly supplied by the sponsored. We studied that, and it was reported in at least 70%. I think it's almost 100% when it's industry-sponsored trials, and patient compensation is very rare. So when you see quality of life data coming from randomized clinical trial, they are not really assessing for financial toxicity, which can really affect quality of life. Last, shared decision-making. I really like this cartoon. Give it to me straight, doc. How long do I have to ignore your advice? I think the patient will ignore your advice if the decision is not informed. We often talk about shared decision. I think it's also informed decision. Do you want to increase your invasive disease-free survival? I don't think that's the way to talk. It takes time to explain the data. It takes time to go into the weeds of the trial. You can really share that with patients. There's no one-size-fits-all way to do that. Some patients don't want to talk too much, but I think that's a way to really have a truly informed decision. The conclusion, adjuvant setting, the bar should be very high because by definition, a huge proportion of patients won't benefit at all. Understanding statistics really helps you. Definition of endpoints and breakdown of composite endpoints, post-recurrence care, particularly relevant for survival assessment, toxicity and quality of life, and financial toxicity. And I think my main point is develop or maintain, I'm in Cambridge, so maintain I think is more appropriate, your ability to appraise the data yourself. I think it's not really a skill. I think it's really being a doctor is really what the decision I'm making, is it worse for my patient? Is it beneficial for my patient? And now the slide that is really important to me in Geneva, Professor Alfredo Adeo, colleagues and friends, patients and their relatives, of course. I'm a member of the Swiss Ethics Committee. I also want to thank Professor Vinay Prasad, which is a mentor and a friend. Aisan Aslam, who is a great researcher of the team. If you want to join the team, you can write us. You have an example of Shruti, which is already a first author of a Lancet Oncology paper on sotorasib, and she co-authored many papers with us. We have also a project that tries to include those aspects, which is called Theorem. And last, I'm a co-editor-in-chief of this new ESMO journal about rare cancers. If you have rare cancer and if you want to submit, I really encourage you to do so. And if you have any questions, thank you.